welcome everyone to Operation Equity, Removing Barriers to Equitable Vaccine Distribution. We have a wonderful range of panelists who are going to talk a little bit about what they do, and then I will ask them some questions. And then the most important part is you will be able to ask questions as well. So if you look down at the bottom of your Zoom screen there and just kind of hover over the bar, you will see an opportunity to click on Q&A. And that is where you can click and type in your questions for the panel. I will kind of keep an eye on that as we go along. And if I see that the questions are starting to add up, I will take a pause and we will move into all of your questions. So starting out, I just want to let you know who we have on the call with us. We have Dr. Jeremiah Owori Hyanga, who is the Director of ECMO at WVU Medicine and the Director of Quality for Division of Thoracic Surgery, the Co-Director of Outreach in Thoracic Surgery, and the Director of the Lung Transplant Program. We also have with us Dr. Clay Marsh, who is our state's COVID-19 czar. He is also WVU Medicine Vice President. We have with us Dr. Ayn Amjad, who is our state health officer and the commissioner of the Bureau of Public Health. And then lastly, rounding out our esteemed panel, we have Secretary Crouch, who is the Secretary of West Virginia Department of Health and Human Resources. So thank you all so much for being here. So as I said, I want to open it up by allowing each of you to just speak a little bit about yourselves, because I'm sure I would mispronounce something. You all are so accomplished in areas that just go right over my head. So I will open up the floor to Dr. Hyanga to take a few minutes to introduce himself and to talk about what he does.
Thank you very much, Director. I am very grateful for this opportunity. I am a cardiothoracic surgeon here at WVU, and I lead a team of dedicated multidimensional professionals and providers that take care of the sickest patients in the state through a program called the ECMO program. It's a mouthful, it's extracorporeal membrane oxygenation. And really what that means is that we take blood, drain it from the patient, put oxygen into it, and put that blood back in the patient when their hearts and lungs have failed. This has become very pertinent in the context of a viral pandemic such as COVID-19, where the lungs can fail and can fail miserably. And we have had an opportunity of treating the sickest patients in the state. We put almost 40 patients on ECMO, and I'm really pleased and proud to report that our results are actually one of the best in the world. So 80% of our patients actually not only survive, but they go home. So it is a matter of pride and responsibility and really humility that allows us to continue to serve in this capacity.
Thank you very much. Okay, Dr. Marsh, I know I'm not supposed to call you that, but
Right, Joe, you gotta call me Clay. So thank you very much. It's great to be here. I want to comment on Owori Hyanga just for a second. Owori is really, truly one of the most talented people that I've had the opportunity to meet as my role at the university. And Owori and his wife, Heather, have been absolute stars coming to West Virginia University from a sort of the extensive training programs in the best places in the country, along with both of them having masters in public health. So these are physicians and people that not only are professionally very, very outstanding, but also very concerned about the state of health for the country, for the world, and importantly for the state of West Virginia. So we could not be luckier to have Rory and what he's doing with the ECMO program, which is really the life-saving opportunity for us to take somebody who has such bad lung disease from COVID or other causes where they cannot oxygenate their blood, and basically put them on a cardiac bypass machine so we can use the machine to oxygenate the blood. And we've had so many people that have lived because of the great work that Rory and the team of people that work in the ECMO program have done. But I think, Jill, what's really important, and I will introduce what I do here just in a second, but it's really important that we have a great team. When I look at Secretary Bill Crouch and our State Health Officer, Dr. Ayn Amjad, and Jill, your leadership at the Henderson Minority Affairs Office, and Michelle, this is really the way that we prosper. And we not only prosper during a very, very critical crisis that's lasted over a year that we call COVID-19, but it's a way that we take what we have learned in our team and our connection and our alignment and our commitment to the higher purpose together. And we start to solve some of the major problems that West Virginia has related to the foundational health challenges we've had, but also to use that as a template for the rest of the country and the rest of the world. And we're not really used necessarily to thinking of West Virginia as that beacon for everybody else. But I think through COVID, we've seen that is in our capability. And so I'm really very optimistic and very grateful for the great work of so many people, because I think the work that we've started with COVID has such promise to really start to solve the real challenges, which is health, well-being, switching the healthcare model from sick to healthy. And the only way we do that is we do it together, and we make sure that we're taking care of ourselves in a different way. So in my role at West Virginia University, and in my role right now as the COVID czar for the state of West Virginia, working closely with all the folks here, I really consider myself so lucky and privileged to be able to contribute. But ultimately, it is about all of us, not just about one of us or some of us, that will make the final difference. So thank you. I'm really happy to be here with you.
Excellent. Thank you so much, Clay. All right, Dr. Amjad.
Thanks, Jill. Just to add to some of the stuff that Clay and Rory said, I'm happy to be here tonight, and just to reiterate some of our working relationships together. I am a native of West Virginia, which a lot of people have a hard time believing, I guess, just based on what I look like. But I was born and raised in Beckley. My parents came to West Virginia about 43 years ago, which tells my age. So I think one of the things, I did go away for school, just like most people, but coming back home to West Virginia was very important to me. And some of the stuff that Clay said, coming together with our state and working with people to be the success that I think that has shown over the past year is very important. So when I just met Rory, I think a couple weeks ago, and then you decided that we were going to have this discussion tonight, which I think is very important. But it excites me to see that we are able to draw talent such as Rory to the state. But I also hope that we are able to retain such talent and also draw in people, to the state, but also people such as myself that grew up here but want to come back to the state and to continue to thrive. So discussions like this tonight, I think, hopefully will inspire young students and other professionals to retain, to come back to West Virginia. So I'm happy to have this discussion tonight and talk to a lot of people. Thank you.
Thank you, Dr. Amjad. All excellent points. I'm glad that West Virginia is making headlines for a lot of good reasons lately. So lastly, we will hear from Secretary Crouch.
Good evening, everyone. It's nice to be with this esteemed group. I'm on a lot of these things with Clay and An. I always like to follow Clay because I actually always want to say, gosh, he just said everything I wanted to say because he's just such a great speaker. But I'm really a manager. That's I've been in healthcare 40 years, which starts giving you an idea about my age, in a lot of different facets of healthcare. And but I guess my role here, if I had to really describe it right now, as Secretary of DHHR, is keeping the train on the tracks and just trying to make sure we move forward with Clay's help and An's help. And I didn't get to meet Ori in a previous Zoom meeting. It's difficult to keep a good schedule. I end up double booked all day. I tell everyone I have one rule: if I have 3 meetings at the same time, then I don't go to any of them. It's good to meet you, Ori, finally. Again, as Clay said and I both said, it's the relationships we have in West Virginia with different parties that are making us successful. And Clay's point that this is kind of really the beginning of a lot more that we can do together. We're number 1 in the country in a lot of areas with regard to this pandemic, and it's leadership, and it's those relationships we have with our local health departments, with our hospitals in West Virginia, our nursing homes in West Virginia. We have weekly calls with all of these folks, and getting reports back from a lot of these folks who talk to their counterparts in other states. They don't have that. They don't have the ability to talk to folks like us. They're talking to people down the line, and those things don't filter up or filter down very well. So we want to keep that up. We want to keep these relationships, and we want to work closely with everyone to try to beat this pandemic. And we are hopefully approaching the 4th quarter of this long game. So again, I'm happy to be here and I appreciate the invitation.
Thank you very much, Secretary Crouch. All right, so we're going to move into a couple of rounds of questions. I'm going to start with Dr. Hyanga. I actually was going to ask you to talk about what ECMO is, but you did cover that because I know it's somewhat complicated, and I appreciate you kind of explaining to all of us what that is. But I will ask you, working in that field, what was your patient load like prior to COVID versus what it is during COVID relating to ECMO?
Thank you again, Jill. We started off in 2018, and we had under 50 patients that were predominantly drawn from having had heart failure or difficulty coming off bypass after an open heart operation, and a few smatterings of influenza A, both H1N1 and H3N2. The program has grown by about 55% every year since, and it was manifest in January and February 2020 that something was different. We were having a large number of respiratory illnesses that weren't testing positive for the common problems. In fact, the first inkling that something was amiss occurred on February 21st, when we had a first case of coronavirus HKU1. And it was at the same time that we were getting reports that there was something else happening. And of course, a few weeks later, the WHO declared it a pandemic. But that was the beginning of a very different type of patient that didn't respond the same way, that didn't test the same way, but acted in a very, very dramatically sick fashion. The course of the first surge was devastating around the country, but we were one of the last ones to actually have a positive COVID-19 patient, as all are aware. But the numbers grew from a referral standpoint very dramatically as we moved into the summer and into the fall, when we had the second surge around the country, and we started to get almost 4 to 5 very sick patients who needed ECMO per day. And it built up over the course of those 3 months of the fall to such a dramatic crescendo that we were worried that we were not able to satisfy the demand. And we run 6 to 8 patients at a time. We have constraints from a capacity standpoint and an equipment standpoint. And it became apparent that there was a sickness out there that was exceeding conventional therapy. And we were not able to match the demand that this disease was throwing at us. So at the end of the day, in 2020 came through with about 35 patients who are dramatically sick, who were on ECMO for a median of 11 to 14 days. And we were learning with each case that we were dealing with something very different and very dangerous.
Wow. It's pretty compelling hearing how everything began to play out for you there early on. And then the other thing that sticks out in my mind is that you were talking about, you were seeing people coming in prior to COVID as a result of influenza. And I think a lot of people don't realize that influenza can be that serious. So I'm glad that you mentioned that as well, because as we go through our vaccinations, I just want to make sure that people are continuing all the good habits that we have developed during this pandemic of washing our hands and really being vigilant about our hygiene to stop spreading not just COVID-19, but all viruses. So thank you. I want to move to Dr. Marsh. And I want to ask you, leading the state's pandemic leadership team, what are the things that you would say West Virginia has done well from an equity standpoint?
Well, Jill, certainly as we go forward with vaccines that are available, we want to make sure that those vaccines reach the arms of the people that have the highest vulnerability to be hospitalized, to get seriously ill, to have to use the capabilities that Rory has talked about, but also people who might be at risk of dying. And so as we look at our population, we realized early that in West Virginia, based on our own epidemiology, that people in nursing homes were about 50% of our deaths residents. And we were able, through the good work of many, many people and leadership of our Long-Term Care Association and Pharmacy Board and our Joint Interagency Task Force, that we were the first state in the country to vaccinate all of our nursing home residents, first and second vaccines, which made a big difference. And we also realized that age played a really important role in the deaths that we saw. And when we looked at our population over 70 years old, that population accounted for 77.5% of our deaths. People over 60 years old accounted for 92% of our deaths, and people over 50 years old accounted for 97% of our deaths. And as we look at our communities of color, our African American community, Latinx community, Native American Indian community, we also know that the testing and vaccinations are lower in these communities and the outcomes are worse. We know from national data that over the first 6 months of this pandemic, that Caucasian white Americans suffered a year of loss of life related to lifespan, but African American citizens in the United States suffered a 3-year loss in lifespan. So as we go forward, we rely on the partnership and the leadership, Jill, of you and Michelle and our African American Task Force and Reverend Patterson, our faith-based community. And I think we've really pulled together. I was really happy to find out, and we talked about this a little bit this morning in our task force meeting, that looking at social vulnerability indices, the CDC has identified that 5 states has done an exceptional job of reaching these populations. And West Virginia is one of those 5 states. So I would never say that we've done enough, that we have achieved where we want to be, because we want every West Virginian vaccinated and we want every community vaccinated. But I think that we're doing a great job together. And this is a theme, Jill, that I think that you'll hear over and over, and we've talked about, that the secret really to our success in the pandemic, to me, is not just the structural issues, the control or the discipline or the identification of these populations we want to vaccinate. It's the fact that we've all stayed together, that we've cared about each other, that we've been willing to wear masks to protect each other, that we've been willing to wait our turn so that our elders and people that are more at risk will get vaccinated first. That is the key. And to me, that is the key that can see us forward and really be that phoenix rising and be the beacon for the rest of the country. Because eventually we need to get healthier as a country. And West Virginia, although maybe not the place you would have thought could lead the way, I think that we have that great opportunity right now.
Thank you. So what do you think we should be focusing on to improve on equity numbers as we move forward?
Well, we know, Jill, in West Virginia, like in many other states, we are having trouble exactly tracking the ethnicity of all of our residents. So the first thing is accurate reporting so that we actually know who we're reaching. The second thing, which I think we're starting to do, but is to create professionals of color to be able to help people in neighborhoods of predominant, African-American, Latinx, whatever, Native American Indian, to feel comfortable and trust that the information that's being exchanged and vaccines are safe, because there's a lot of misconceptions, a lot of fake news or whatever you want to call it. But I think that empowering multi-ethnic groups of professionals to be able to serve communities so that we build trust and that we build capability and capacity, in addition to in-person places, faith-based communities and faith-based leaders as well, but also mobile capabilities. And we're starting to open that up because we have a lot of citizens who are homeless or socially vulnerable or homebound that also are vulnerable parts of our population that we need to reach. So I think it's a multi-pronged approach. And ultimately, I think that this is not only important work for COVID-19, but it's really important work for us to extend the capacity and the access to all of our healthcare capabilities, but also to start to think differently about making sure that we are working as neighbors and as friends and family and communities to start to build that resilience, that strength, switch from fear and scarcity to love and abundance, because ultimately that's what makes us healthy, I believe.
Thank you so much, Clay. All right, Dr. Amjad, you have worked extensively in underserved communities. I was reading about you for a long time before you ever became our state's health officer. And I just want to ask you, from your experience, what do you see as both the pre-pandemic and the post-pandemic challenges that typically prevent people from accessing adequate health care?
Jill, at least as far as West Virginia goes, I think transportation is a barrier, especially in the rural parts, and that's even for some of our larger cities here in West Virginia, so, and especially in my experience. So transportation here is a barrier, even for patients who do have transportation, due to costs of gas, as simply as that can be a barrier. So I've come across a lot of patients that simply couldn't afford the gas to come to a doctor's visit. So because we don't have mass transportation here with a bus or a subway system, I think that's a big barrier here. So I think that is something even pre and post pandemic that we have things. Telemedicine that we have encountered, especially this past year, has helped. But also with that in mind, a lot of people are not comfortable with telemedicine because they're not comfortable speaking with the physician, obviously over, even like a Zoom or FaceTime. In addition to that, if they lack the Wi-Fi access has been a barrier I had noticed. So those are things I believe are a big barrier. And then in addition to that, the lack of even primary care doctors, nurse practitioners in an area are also barriers that I had noticed pre-pandemic or even now when we discuss that with patients across the board.
So what would you see as some improvements that the state might be considering to meet some of those challenges? I know, everything has significant fiscal notes to them when you're talking about solutions, but, just thinking realistically, is there anything that we could be doing in the near future to meet those challenges?
I'm a big proponent of preventive medicine, preventive health, so we discuss that a lot. Obviously you want to prevent someone from walking into your clinic with a bag of medicines. That would help a lot. So preventive health care, we always promote medical students going into primary care, family medicine, internal medicine, but that's obviously not a sexy medical degree. People don't want to do it. So, we promote those types of things, but also increasing access to care. People do talk about, bringing physicians or nurse practitioners into people's homes. That's one barrier. It's easier to say, oh, you want to open up some type of busing system or transportation for people. Also, you do have other systems of where people will come and bring, some type of transportation and bring veterans to the clinics and things like that. There are other options of ways to bring healthcare. Telemedicine, I know they're working on ways to make it more fee for service so that, providers are being paid. So telemedicine is an option. I know during the pandemic, before providers were only being paid if it was a face-to-face type of telemedicine. Then they changed it where it could be a phone call. So the patients didn't have to see you. They could be paid if you talk to them on the phone. More patients were comfortable with that. So I think there are ways around it and there are things to improve upon it. But that does take a lot of time and a lot of creativity and things for patients. But I think there's a lot of stuff that needs to be done in order to address all those issues moving forward.
Excellent ideas. Thank you very much. All right, so we will move to, I have a question for Secretary Crouch, and then we'll pause for a couple of audience questions. Secretary Crouch, you have been working for an entire year now to increase testing and now vaccine distribution in communities of color. Can you tell us what those efforts look like currently? You're muted, Secretary Crouch.
I'm sorry. Yes, the governor asked me to get involved with this task force with you early on in terms of the creation of the task force. And Jill's done just an absolutely terrific job, by the way, in all aspects of this. We started out trying to see what kind of advice we could get through the task force, through individuals who understand those communities better than we do. Everyone points to Charleston and says, the decisions are made in Charleston. We're really trying to get input so that they're reflective of a broad group. We started out with testing. I'm sure everyone will recall, had a difficult time getting African Americans to show up for testing. We could not get folks to do that. We started out at about 1%, 1.5%. We ended up stuck at 2% for a while of the testing being done. We're now at 4%. And of course, the African-American population as a percentage is about 3.6%, I believe. So we're doing well now. We've gotten people testing. One of the reasons that increased was through Reverend Patterson, who's been mentioned a couple of times, with the Partnership for African-American Churches. And he developed some mobile teams that can go out and do testing in the communities of color and minority communities, so that we really go where the individuals are, where the people are, rather than ask them to come to us, and which is a tried and true approach in terms of community organization and services. So that was going so well. When we finally started getting shipments of vaccine, I actually called Dr. Patterson, Reverend Patterson, and said, can you do the same thing for vaccinations as you've done for testing? And it didn't take him long to think about that and say yes, he would do that. So he's now got teams going out throughout the state and is increasing the numbers in terms of immunizations. We're now today at, I think, 2.2%. We were struggling at 1.5, 1.7. That's starting to come up now because we're starting to see more numbers. So we've got to get that number up further. Folks have heard a lot about the registration system, the state registration system. We have, according to the data we only have 1,127 African Americans registered in that system. That is not enough. And I actually earlier today started this morning, but they finally got to manning the phones about 2 or 3 o'clock. We're calling every one of those 1,127 people in this system. We're going to have that done by this evening. And we're going to see if we can see if they've gotten their immunization, see if they've been vaccinated or have not, so that we can then schedule them for a clinic next week if they have not. So we're working on a new system here where we go to the people. We go to this list and we contact those individuals rather than wait to try to get for them to get another call in the community. So we've done a great deal. We have a lot more to do, but we're really starting to see those numbers come up now, and that's what we need.
Yes, that is outstanding news. I have a question that came in via email that I will read. It says, a significant barrier we are facing in our family is the registration and waiting to be approved process. My husband fits the age criteria, has been registered in the system for weeks, and has heard nothing as far as qualifying to schedule an appointment. Meanwhile, we have neighbors and colleagues calling every pharmacy around and getting last-minute appointments to get vaccines. Why have the registration process if the distributors circumvent it anyway? Is there a simpler way to enable more transparency around appointment scheduling? Even having an idea of where you are in the queue could be helpful. And that's from Nicole.
Yeah, good question. And we've been struggling with this system. We have over 410,000 individuals registered in the system. The first purpose of developing this registration system was to take these thousands and thousands of calls a day off of the local health departments, the hospitals, and the FQHCs who are getting calls. And they didn't have answers to folks. And we've done a little bit better, but we haven't had answers either. And the system has changed. We constantly pivot in terms of what the situation is. And what happened is we pushed vaccine out, as Clay talked about, by age. We've tried to, first of all, we immunized nursing home patients and nursing home staff and hospital staff who worked in the emergency room, worked in ICU, and worked in COVID units. We then started pushing vaccine out by age throughout the state. So some counties have more elderly population than others. We now started kind of equalizing those doses that go out. So individuals who register should be called by the county that they live in for an appointment. But because that hasn't worked too well, we're calling everybody. So we're going to actually, once this with this list of African American and minorities is complete, we're starting with 80 and over. And we're going to call and we're going to schedule an appointment for those individuals for the following week. So that's something new that we're implementing right now. We should have that in full force here in the next, probably by tomorrow afternoon, where we're calling and we're scheduling folks into a clinic in their county, so that people, and we're doing that by date, so that folks who've been on the system the longest will get called first before others, and also the age and other criteria for that. So that's a great question. That's something we've been trying to figure out how to deal with. Part of the issue too, let me say, is that the federal government pushes doses to pharmacies in West Virginia. All 94 Walgreens in the state get doses of vaccine directly from the federal government. Those do not come through the state system. And now we've added about 54 independent pharmacies. So we have doses that go out, and FQHCs, federally qualified health centers, are now, I think we have 4 of those this week, and that number is going to grow. So there is a lot of vaccine that flows throughout the state into the counties that we don't really have eyes on. So people are calling and getting in faster because of the additional vaccine going to pharmacies and FQHC. So we're going to level this out. We're going to get that list pared down, hopefully in the next couple of weeks, get folks vaccinated, and then we'll have a system that'll work a lot better for folks, I believe.
Excellent. Thank you so much, Secretary Crouch. All right, so I see that Clay has been frantically typing and answering additional questions that have come in. So participants, you should be able to see the questions that have already been answered. There was one in particular that I was going to read aloud, but I'm glad that Clay did answer it concerning people with disabilities and what we are doing to make sure that they do have equitable access. And Clay has said that they're using the Johnson & Johnson vaccine to bring vaccine to folks with IDD, particularly in congregate settings. So thank you so much, Clay, for answering that really important question. All right, so I want to go back to Dr. Hyanga, and just if I could, let me close that out, ask you, I know that you have been attending local meetings in your community and working with the community to learn about the specific needs that aren't being met there. What are some of the concerns that have been brought to you from the community regarding vaccine distribution?
Thank you, Jill. You know, a lot of the issues and the concerns have actually been raised in this dialogue right, just in the past 15 minutes. And really, it seems that if you could categorize where the concerns truly stem from, because really speaking to Dr. Marsh's concepts about scarcity and abundance, I think I completely agree. And I think there are 3 categories, and the underpinnings of these are a lack of trust. And so if you look at the lack of trust on one hand, there's what I conceptually believe to be the Tuskegee phenomenon, where the 1932 study conducted by the US Public Health Service still exerts a lot of influence on how people perceive treatment, therapy, and when you add the novelty of a vaccine without the context of trust, it really becomes a hard pill to sell. And many people feel that medical encounters are transactional, and that transaction will either result in them being tricked or being hurt or even being killed. And I had a very poignant conversation with my mother, and I was very surprised that she was so scared. And I consider her to be a forward-thinking, educated thinker, and she was very frightened of the vaccine. And I felt a certain betrayal to her that I wasn't there to navigate her through some of these thoughts that she's clearly been having for weeks. There is a lack of trust, and those are the underpinnings of the hesitancy, the skepticism. The second category, I think, it's a more cognitive, I like to refer to it as the AstraZeneca Netherlands group, where it's just a feeling that the vaccine has been too hasty in its development, that there hasn't been enough testing, that it is too new, the side effects are unknown. And so there is this unwillingness, therefore, to trust it. And then the third group, I think, are the social determinants of health group, whereby, as we have heard from Dr. Marsh and Dr. Amjad and the secretary, the disabled that can't travel, the indigent that can't afford to travel, the communities in which there are no recognizable purveyors of the vaccine that can be identified as the Reverend Pattersons, or the people to whom a commitment to the community can be attributed. So where trust has been fractured, it's very difficult to bring these mechanisms to bear without looking at and acknowledging how things got there in order to try and figure out why they're there in the first place.
So what would you say to people who are still vaccine hesitant? I know that it seems that a lot of the sentiment in the Black community has started to change, and we're not seeing as much hesitancy as we did during the initial rollout. But for those who are still reluctant to accept the vaccine, what would you say to them?
Well, right now I would say what I said last week. I would give this to my mother. I would give this to myself. I would give this to my wife. I'd give this to my son. This is not a trick. This is not some weird experiment that is designed to exterminate a population. Because many times I've seen conversations about vaccine hesitancy that don't really address the real issue that is causing the fear. And so what I've learned in disagreements, for example, with my loved ones, is that if I don't acknowledge what it is that they fear, it's difficult then for me to offer a solution. And trust is so fragile, it doesn't return on command. And I really looked upon this pandemic as an opportunity for me to do more, to build bridges, and not expect it to be someone else. Because I have had to enroll patients in new therapies, monoclonal antibodies, and I have seen the despair and the distrust, and I have seen a spectrum of different acknowledgements and appreciations and understandings based on race. And once that is acknowledged, I think then I can begin to figure out what I need to say in order to allay an anxiety. And I think that has to be continued, not just through pandemic times, but in non-pandemic times, so that we can build what Dr. Marsh referred to as that platform of abundance and start to mitigate some of those fears and allay some of those anxieties.
Thank you very much. All right, so I'm going to move back to Dr. Marsh. I was reading that there is a 75% of the population would need to be vaccinated in order for us to reach herd immunity. Number one, is that true? And number two, based on the vaccine distribution where we currently stand in West Virginia, will we ever reach herd immunity and be able to rid ourselves of the masks and the distancing?
Well, thanks, Jill. That's an important question that I think many people have tuned in on. And I would just say that right now, I don't believe herd immunity is possible. And that sounds really negative, but it's not really so. Herd immunity really talks about the number of animals in a herd that needs to be infected and recovered to block the infection spreading through. And ultimately for us with COVID-19, we would need about probably more like 80 to 85% of people who were infected, recovered from that infection, and immunologically capable of blocking COVID from infecting them. We know that there's 2 or 3 different issues that probably will prevent that. So number one, right now, no vaccine is approved by the Food and Drug Administration to be administered to anyone under 16 years old, which means there's a whole bunch of people that right now will not be able to be vaccinated. And there's studies going on, like Rory and Heather's son, Simon. He can't get, what's he, 4 years old, Rory? Yeah. So he can't get vaccinated because right now the vaccine is not proved to be safe for him, but there's clinical trials going on now to try to change that. Number two, we know, Jill, that people that get native infection and recover from COVID-19 can get reinfected with some of the variant viruses. It seems like that immunization is a better protection longer term than recovering from the native virus. So some of the viral strains, the variants like the Brazilian variant, for instance, has reinfected people in Brazil. So therefore, you can't get herd immunity if that same population can get reinfected, because the implication for herd immunity is that you have so many people that will stop the spread of the virus that it dead ends the virus. It just stops the spread because too many people are, can block the transmission. The third issue is that we know that while we see a lot of vaccine in the United States, many countries do not. And when we look at the world population, and there's been a tremendous amount of conversation about not only how the United States is doing for us, but what is our place to be able to help people in the developing world? Because as long as there's people that can't get vaccinated, the virus will continue to mutate. So the time the virus changes, makes genetic changes, because it's kind of a messy replicator. When it's reproducing, it makes a lot of mistakes. And eventually these mistakes can add up and give you these variants, viruses that gain an advantage, either infect easier, cause more problems, make people sicker, cause people to die. And the concern is that over time, even if we get a bunch of people in the US vaccinated and get up to those levels, if we don't do that across the whole world, then there's still going to be viruses that will circulate that can perhaps even evade some of the vaccine-based immunity that we have. So I think that the key is that we want to get as many people vaccinated as possible, because these vaccines are really good, really safe. Number two is we want to keep doing those smart things, wearing the mask, staying physically distanced, being careful, taking care of ourselves and each other, because we know that right now we're not finished with COVID-19 yet. And over time, COVID will likely get less virulent, less dangerous to us, and COVID will have to learn to live with us for the long term. But right now we are having to live with COVID. So it is really important, as Rory said, and Ein said, and Bill said, and Jill, as you've said, we really want people who have an opportunity to get vaccinated to choose to be vaccinated. We've all been vaccinated ourselves. My mom, my 90-year-old mom's been vaccinated. My 27-year-old daughter's been vaccinated. My wife, which I won't mention her age for obvious reasons, she got her first dose because she was just made eligible. So ultimately, all the people I love the most in my life, absolutely, I want to get vaccinated. But I think that this trust issue, trust happens over a long time and can be lost in a very short time. So we really want to build trust. And the ultimate opportunity that we have here in West Virginia is not to be number 1, 2, 3 on a list. That's great, but that's transient. It's to make sure that we both look out for each other here, but that we start to trust each other, to develop relationships, to feel connected, to be serving a higher purpose. And that higher purpose is helping each other. And we're saving lives here, not only by vaccinating people, but by other people wearing masks, by being careful. And ultimately, we all shine brightest when we serve others. And I think that this is a shining example of the culture that we have in West Virginia that we're all so proud of, that the rest of the world is now seeing. But our work is not done in COVID. And when it is done in COVID, it is not done to promote a better level of health and well-being and life quality for every citizen that lives in the state.
Wow, thank you so much. So going back to Dr. Amjad, as of today, I had written that it's 2.5% of all those vaccinated are African-American, but Secretary Crouch just corrected me. It is 2.2%. of all vaccinated are African American. So people who are watching this webinar right now, what can they do themselves to improve on those numbers?
There are two things that we can ask anyone to do to get vaccinated right now, Jill. So they can either sign up online with our online system, or they can call our number, which is, I had to write it down. So it's 833-734-0965. So those are two ways to register to get vaccinated. So we've had reports that most elderly people may not be comfortable registering online. Maybe they're not comfortable with that system. So, but what some people might not understand is they can have a family member do that for them. Younger people can do it a lot quicker, and you don't need much information. You do need to set up a password for them. But I think, you and I have talked about that. You were able to help someone do that for them. And, then I had to help a patient do that for themselves, actually. And I did that with them on the phone in less than 5 minutes. So she gave me her email address. I made up a password for her, and you just need a little bit information. So they can do it that way, or they can call our number and someone on the phone will help them register. So in order to increase these numbers, that's what we're asking people to do. But if an older person's not comfortable, we've asked, a family member to help them do that. So I think that's what we need people to do in order to get vaccinated. And it's just like asking a family member to take you to your doctor's visit. Obviously some older people don't drive. A lot of their grandkids or children take them to the doctor's office, but we need that kind of support right now in order to get our elderly people vaccinated quicker. And that's the quickest way. So whichever way people are comfortable doing. But I think some people think they need to do it themselves because, of course, some privacy information, but you can have family members do that for you. They can even call for you and get that kind of information out there registering. So that's what we would ask people to do out there.
Okay, and then as far as the groups that are eligible, I thought that the governor did open it up some this week. Is everyone over 16 now eligible, or are there still groups waiting to be included?
It's 16 and older with some comorbid conditions, and the list is on our DHHR website. So 16 and older with a list of healthcare conditions. I know Clay has memorized them better than me, but it's on our website, but I think Clay can probably memorize them a lot faster. I'd have to look on my little cheat sheet on my phone somewhere, but I don't know, Clay, if you want to list them out, he's better.
Well, I would say real briefly, Jill, it's anybody 50 and over, any essential worker at 16 and over, and the pre-existing conditions include obesity with a BMI, body mass index over 35, which means a 5-foot person weighs about 180 pounds, a 6-foot person weighs about 260 pounds, high blood pressure, kidney disease, liver disease, lung disease, heart disease, any kind of transplant, any immunocompromised state, pregnancy, sickle cell anemia, blood-borne disorders, pulmonary fibrosis, chronic obstructive lung disease, hypertension. I'm starting to block here, but it's really asthma.
Diabetes.
What's that?
Diabetes. I got
diabetes. Yep. It's a variety of really medical conditions that the Centers for Disease Control identify as having people at increased risk for severe disease, hospitalizations, or death. And we really decided, the governor decided, that we didn't want to open it up completely yet because we wanted to make sure that we were still disciplined to reach, as Secretary Crouch said, our over 80-year-old population, our over 70-year-old population, because we know that's the group of people that most likely dies from COVID-19 and becomes hospitalized. And then we want to get to our pre-existing medical group. And then I think that we will be able to be substantially ahead of where President Biden has committed us to open it up for all Americans May 1st. I think West Virginia will be opened up before that, but that will be the governor's decision based on the recommendations of the people on the call and beyond.
Thank you. And so before we take it to all Q&A, I do have a couple more questions for Secretary Crouch. Secretary Crouch, achieving equity means directing extra resources to where the greatest need is present. Is there a formula that the state is using to determine how the doses received get allocated to each county?
Yeah, thank you, Jill. I mentioned a little bit earlier about the priorities starting out with the elderly population. And Clay says it so eloquently. It's age. We're looking at the folks who are at highest risk of hospitalization and death. So that began our journey with regard to the vaccine. We've expanded that, and Clay just talked about kind of the last expansion, which was to those with comorbidities. At some point here in the next several weeks, it's going to be open more and open to everyone. The issue of trying to get to populations that are high risk, it gets more difficult as we look at these populations. I talked a little bit about we're having difficulty getting folks to register. Only 1,100 individuals in the registration system for the state that are African American is an indication that we're not getting the word out. We're not doing what we need to do to get folks to register into the system so that we can get to them. And again, we'll have all of those folks called by this evening. After that, there are more below the age 65 and over. There were 5,000 total individuals. So we've got about 3,500 more we can reach out to. But at some point, we're going to run out of arms to put needles in terms of the African American population and minority population. So we really need to educate folks. We need to get the word out that, as Dr. Hyanga said, this is a safe vaccine. This is something certainly all of my family has taken that are eligible. It's a vaccine that will save your life. So we've got to get the word out to folks to do more of that. I mentioned Reverend Patterson. He is actually doing home visits now. And keep in mind, this has been a terribly complex process. We started out with a vaccine that had ultra cold temperatures of minus 90 degrees. We had handling issues. We had transport issues. We had to make sure everything was in place. We had to make sure we had enough people when we opened a vial that we had arms to put that vaccine in. We did not want to lose one dose. And to my knowledge, we have not lost a dose. Then we got Moderna, which is a little different, didn't require the cold temperatures, but when you open a vial, you have 6 hours in which to use that vial. So we had different characteristics for that vaccine. Luckily, we have Johnson & Johnson now. We got, as I think Clay said, I think we got 15,500 doses last week. There's a little delay in that manufacturing ramping up so that we can get more and get that on a routine basis. But that vaccine gives us a lot of possibilities in terms of individuals who can't travel and who one dose and done is really the way to go. But Reverend Patterson is actually going up into hollers and going into homes and injecting folks in their home. So, and we have a lot of folks doing that. Dr. Sherry Young here in Kanawha County does a lot of that. And we push her information if we get somebody who registers onto the system and they contact us and that they can't come out, they're registered, but they can't, even if they get a call, they can't come to the Coliseum in Charleston or WVU in Morgantown to get a shot. So we have more and more folks going out to these people. So we're looking at more mobile approaches to this. We've got to get out to everybody. And again, the approach needs to be, we're going out to them rather than waiting on them to come to us.
Thank you very much. So that was all the questions that I had. We will open it up to audience questions for the last couple of minutes that we have available. I do see one that says, I know many people are concerned with how COVID is affecting the homeless population. Some folks I know have mentioned that the Johnson & Johnson vaccine is going to be very important in getting homeless individuals immunized. Is there anything in the works specifically targeting the homeless population?
I can just say, this is Bill, I can just say that that has already been done. The first few doses of Johnson & Johnson went into individuals' arms, homeless individuals' arms in Kanawha County. Dr. Young got that, went out late at night. I think she stayed out till midnight injecting folks when the Johnson & Johnson came last week. So we are seeing that. We are looking at that population and trying to do as much as we can there as fast as we can.
And maybe I'll just add, Joe, real briefly, and Bill, that all of the doses of Johnson & Johnson are really allocated to focus on individuals either homebound or socially vulnerable or who have unstable housing. So it's really being used so that it can be taken in a mobile sense or a bring it to people in certain situations and certain places where we can capture groups of people who may not be able to show up for the second dose or may not show up for the second dose, and people in congregate settings, say, who may have intellectual developmental disabilities where, again, 2 shots may be really traumatic. So this is what we are using at this point, the Johnson & Johnson vaccine, to target these, unique populations that we have.
Thank you very much for that, Clay. And we were just at the top of the hour. I just want to make sure that we answered all the questions. There's some very nice thank you messages coming in. Thank you, Lulu, for joining us. I really do appreciate you being on here. I want to thank all of our esteemed panelists for your tremendous work in pandemic response. I know that it is very tireless and in most cases, thankless work. So we really do appreciate you. We appreciate you coming on and speaking directly with the public and answering their questions and concerns. So thank you, Dr. Hyanga. Thank you, Dr. Marsh. Thank you, Dr. Amjad and Secretary Crouch. Everyone have a great evening.
Thanks.
Thank you, Jill.
Thank you.
Thank you.